talking about using AI as a tool in public health. I am Anita Namuyaba, Global Health Cause Community Impact Manager for Eastern Africa, and I'm excited to be here with our exceptional speakers and moderator. Traditionally, AI has found its primary applications in clinical medicine and in healthcare administration. The widespread integration of AI in public health, though a promising frontier, is a relatively recent development. It was during the emergence of the COVID-19 pandemic that AI truly began to see its potential in public health. As the pandemic spread across the globe, it became clear that AI had the ability to rapidly track the virus, predict outbreaks, and optimize resource allocation. Public health systems, many of which were overwhelmed, began using AI to analyze vast amounts of data, identify patterns in disease spread, and model interventions that could mitigate the impact of the crisis. And while these applications are remarkable, they are only the beginning. As AI technology continues to advance, its potential to reshape public health grows rapidly. I am excited for this discussion where we'll be discussing the appropriate uses of AI in public health, the challenges of using AI in public health, and its future in the space of public health. It's therefore my honor to introduce our moderator today, Jessica Mayenda. Jessica is a GSC alumni from the 2017-2018 cohort and was based at Planned Parenthood Association in Zambia. Jessica is currently the Senior Manager for Digital Solutions at Village Reach, where she leads the Health Center by Phone program. In the program, they leverage mobile technology to deliver healthcare services across 6 countries, including Malawi, Mozambique, and Kenya. Jessica is at the forefront of integrating AI in health solutions, focusing on enhancing diagnostic capabilities, improving patient triage, and strengthening healthcare system efficiency. Jessica will be introducing our panelists for today's discussion on using AI as a tool in public health. I hope every one of you will also share your insights, comments, and questions in the chat and Q&A box. We hope to get as many of them as possible. Jessica, Elena, Dr. Hamid, and Gideon, thank you so much for joining us. Jessica, I will pass it to you to introduce yourself and our panelists today. Over to you, Jessica.
Thank you so much, Anita. Thank you so much. I'm so glad to be here. And I think it's a very timely conversation. I don't know if you can see in the background, myself and Elena are actually in Nairobi at the Global Digital Health Forum. And for the last 2 days, it's been a point of discussion speaking about AI and its use in public health. I'll start introducing our panelists. We have great minds on the panel, and I'm so happy to be part of this conversation. So I'll start with Dr. Hamid. So Dr. Hamid R. Ikbia is the university professor and director of Autonomous Systems Policy Institute at the Maxwell School of Citizenship and Public Affairs at Syracuse University. He studied computer science, cognitive science at Indiana University, and he's interested in how AI and computing mediate the social, economic, and cultural aspects of modern life. He's the co-author of a number of books on these topics, including Artificial Dreams, The Quest for Non-Biological Intelligence, Cambridge University Press in 2008. I hope I say this correctly, but Heteromation and Other Stories of Computing and Capitalization, MIT Press 2017. Big Data is Not a Monolith, MIT Press 2016, and Universal Access and its Asymmetries, The Untold Story of the Last 200 Years, MIT Press 2022. Welcome to the discussion, Dr. Hamid. Our next panelist is Gideon Abako, who is a GSC alumni from the 2023-2024 cohort based at the Ministry of Health in Uganda. He's the research lead at FCDO or ELRA funded AI for Humanitarian Research Grant, where he leads an AI integration in health supply chain optimization for human efforts. He's also driving the integration and development of AI assistants to enhance customer experiences on the OBI Coach platform as a customer engagement advisor. With a background in biochemistry, Gideon has extensive experience in nutrition and health programs across Africa, applying AI to precision nutrition and digital health innovations. His work is centered on driving AI-based interventions to improve health outcomes, especially in underserved communities. Welcome, Gideon, to the discussion. And our last, my fellow roommate, or in the same room, so it's quite different to speak to her, but she's studying over there. So Elena Kozane, who I worked with in the past at Vayamo, is a JHC alumni from the 2019-2020 cohort based at Jepaigo in Uganda. Elena Kozane is the Deputy Director of Strategic Partnerships and Innovations at Vayamo and brings over 10 years of professional experience in education and partnerships with 6 years of dedicated experience in health development in Uganda. Her background includes leading transformative health projects that focus on equitable access to health information and services. At Vayamo, Elena oversees large-scale public health research, investigating the effects of accurate information on behavior change among women. With certificates in SEED, which is Seeking Educational Equity and Diversity and Human-Centered Design, her focus is on designing and implementing health programs for underreached communities to improve health outcomes. So that's our group of panelists, and I'm going to just give a nice roundup of what we're going to start talking about today. So with the emergence of generative AI and ChatGPTs, many of you know that AI refers to the ability of software programs to simulate context-sensitive responses or conversations with human beings, often in natural language. But AI is much more than that. AI encompasses a broad range of methodologies and technologies, from computer vision and natural language processing to machine learning. In the context of public health, AI holds immense potential to improve disease surveillance, predict health trends, optimize resource allocation, and even personalize health interventions. But how is this actually happening in the field? What are the challenges, opportunities, and ethical considerations that we need to keep in mind? I'm very fortunate, and all of us are very fortunate to have a very distinguished panel today with vast experience. And as we hear, they have different expertise in the area of AI and public health. Our panelists come from different backgrounds, and they will each share insights into their work, offering us a more comprehensive understanding of how AI is shaping public health. We'll start hearing from each of our panelists. We'll start with Dr. Hamid. You have about 3-4 minutes to just give us an overview of your work, Dr. Hamid. Over to you.
Thank you, Jessica. Hello, everyone. It's a pleasure to be here. I have to first provide 2 caveats. First of all, it's early in the morning. I'm in California, so I'm not as sharp as I should be. I already tried to get enough coffee to wake me up, but I'm not sure if I'm there. Second, that I'm not an expert in health. I'm an outlier here. So I'm here really to learn more than to provide insights. But with that in the background, I have been studying AI and researching AI for a few decades now. And as Jessica just said, although generative AI came to public attention just recently, AI has a much longer history. There have been ups and downs, and we don't know yet if this current upsurge of AI is yet another of those moments of excitement. But my belief is that this is going to stay, although we don't know exactly in what shape. And this is important to keep in mind that things might change. Generative AI is not the only type of AI, and it might not be actually the best approach in many respects, including in the intensive energy uses of these systems and so on. So I just wanted to highlight that. But one reason that I accepted to participate here is my belief that one of the best applications of AI actually is in the healthcare arena. Whether it is drug discovery or public health or surveillance, health surveillance, and so on. So I would like to highlight the fact that we should push the development of AI more and more towards applications in these areas, as opposed to, let's say, some more cultural social media stuff. Now, in what form? I think that's the topic of the conversation. I'm looking forward to having to hear from my colleagues and also maybe provide some ideas myself. Thank you.
Thank you so much, Dr. Hamid. I really resonate with what you're bringing out. And I was reading an article earlier today where they were emphasizing that, AI is not the solution, and it's a tool, and we need to focus on the problem. And I think it's a great discussion to think about, and a great way to think about it. I'll move over to Gideon. You work in AI for health supply chain optimization. Could you please share some of your work and how you're using AI in your work?
I think you are on mute, Gideon.
Sorry. So thank you very much for having me. I am Gideon Abako. Let me just talk a bit about my work in general, then I'll focus on the health system supply chain optimization. I am a framework developer and a project manager for the International Foundation of for Recovery and Development, where, of course, I lead the AI integration in humanitarian health systems. I also advise on the OB Coach project at Evolve Wellness as a customer engagement advisor, where we walk through AI implementation in the health and nutrition platform. I am also the founding director of Neurovox, leading research on the EU AI Act implementation and working on the AI and language partnership with UNDP and Italia G7 presidency. Yes, I try to bridge the gap between AI and health. I think it is my interest of my focus because for the past 2 years, I have always been machine learning, been focusing on machine learning. And then with the advent of ChatGPT, AI blew up. So a lot of people think AI started yesterday. No, it didn't. Just like Dr. Hamid said, he's been on AI for like a very long time. So the passion has always been there for me. In my work currently doing the AI in humanitarian supply chain, I do predictive modeling. Now we are building an AI framework that can analyze historical supply chain data and external factors to be able to bring about disease prediction patterns and then help to optimize supply chain to meet this demand. Then we do route optimization using machine learning to these AI systems are designed the way we are designing the AI system, the framework, we are designing it in the way to generate delivery route based on real-time data, the conditions of the road, the security situations. You understand that in the humanitarian settings, things are really unpredictable, things are dicey, things are not very okay. So we try to capitalize on these challenges and see what can our AI do to solve this problem. Then on low resource environment, we are also ensuring that our system is adaptable to the conditions, providing friendly interfaces, basic mobile app application, making it accessible. Even, what's the purpose of a system if you can't use it down to the last person? So we have applications like USSD, edge computing. That way it is able to adapt to the low resource settings. It is an interesting work because just like Dr. Hamid said, AI is an evolving field, and having to get immersed in this work, you make mistakes. You see challenges, you adapt, you learn, you grow, you improve upon. And I feel very privileged to be leading this work with artificial intelligence. Thank you very much.
Thank you so much, Gideon. I think you are setting the tone for the next presenter. And the one thing that's really come out is the need for technology to reach everyone. I think if we're trying to get to universal health coverage, that's very key. And it really brings me back now to speak to Elena. You're working on generative AI solutions for personalized health guidance in offline communities. It's something that Gideon has just mentioned, the most basic technology and using AI in that space. Can you please share a little bit about your work?
Yes, thank you so much, Jessica. And thank you to my colleagues on this call as well. I appreciate you're coming from a technical space. And now I'm going to pivot a little bit to talk about use cases for generative AI in ways that are expansive and equitable. So in short, at Viamo, we care about democratizing information. There's about 2.7 billion people who are offline, which is almost a third of the world's population. And they don't have access to the internet. They don't have access to a search engine because they're not online. Next slide, please. So this here is OC, and she's our archetype for all the people who are disconnected digitally. And we're here at this conference right now. And what's amazing is we're hearing so many innovations and apps and platforms and systems that are being created to bring Gen AI to the forefront, but they're not necessarily designed for OC. We can't wait for the OCs of the world to come online. They have needs now, and they deserve access to information right now. And what's interesting, it's not just infrastructure that's a barrier for OC coming online. There's challenges around literacy, around digital literacy, affordability, content not being in her language. And so that's why at Viamo, we design from the bottom up and work with the technology that people already have, which are usually simple feature phones, non-internet enabled phones. And we work in a voice-first manner. Next slide, please. So Viamo is a connector. That's really our functionality. We're the digital connector between all of the organizations that want to reach them, or for OC to reach. So for them to reach OC and OC to reach them with information, with trainings, with resources. And Viamo has a platform. We work in about 22 different countries across Africa and Asia. And our platform is the way in which we're able to do this. OC is able to experience the platform through a short code, calling in toll free, and she's able to get in touch with this interactive voice response menu that has a myriad of different services, trainings, games. She can learn about HIV testing. She can be referred to health facilities. And this interface means that OC for the first time can have rudimentary search capabilities. She can call at a time and place of her choosing, free of charge, in her local language with tech she already has. So it allows her to meet her moment of need. Now coming to AI, on to the next one. So realizing that we need to reach OC before she comes online, we've been working to optimize our generative AI solutions with OC's current technology. So essentially, she doesn't need to come online through landline. She doesn't need a computer. She doesn't need social media. She's able to access generative AI through our platform simply through her mobile phone. And there's really two ways that we do this. There's two products that we do. One is called Ask Viamo Anything, where we connect it's a domain unspecific voice companion. So that means she can literally ask about everything and about anything that she wants through speech to text and text to speech technology. She can call in and get connected to the World Wide Web without ever coming online. There's another product we do, which is called Ask an Expert, which is when the voice companion model is only trained on specific domain of content, like a specific domain of sexual reproductive health, of agriculture, and she's only able to ask questions about that and receive responses. So how we've integrated generative AI, we've already integrated in almost 7 different countries. And what we've seen in these countries, next slide, please, is that 30% of the questions that are being asked to the system are about health. So when she calls in to ask a question, she gets a conversational response back to that question. And what we know is our users want to know about health. Over 30% of the questions are related to this. On to the next one, please. So what we found in starting to launch this technology is that first and foremost, focusing on Zambia, that's been our longest running pilot, a third more of the questions are being asked by women than by men. We see that women get more benefit from this service. There's a privacy component to this tool, especially when thinking about the sensitive questions that people have, especially in the world of health. This is an exciting tool that could move the needle on closing the gender digital divide, an anonymous private space in which to ask the most sensitive questions. We also see that it's being used as a search engine tool in a really real way. The cholera outbreak late last year in Zambia, there's an uptake in Google on questions being asked about cholera. That same uptake was seen on the Viamo platform. So this is now an option for people to get resources they need with the platform that they have access to. And the last piece here is a word cloud of the types of questions that we're seeing come up and the types of things that people want to know about. My last slide here is about the M&E component of all this work. Anita, just to the next slide, please. Oh, maybe this was the last one. Could we go back? Sorry. Okay, well, to this point, there's a really exciting component of M&E and the types of learnings we're taking about out of this. We get direct insights into what people want to know. We get to hear the language, the framing of the actual questions, and there's a lot of data. So we can know what the gaps really are. With the transcripts of OC's questions, it's really a game changer for adaptive program management. There's so many institutions and donors and implementers who are funding programs without actually centering OC's voice and her needs at the center of this. So what's exciting is this tool, this voice first generative AI tool, can not only benefit OC, it could benefit something like community health workers, primary health workers in different settings to access what they need when they need it with the tech they have. That's me.
That's amazing, Elena. And I'm biased because on my I think we're very much in similar work fields, and we are also testing AI in our call center. So we build national health call centers as Village Reach, and we're exploring how we can use AI to reduce the load on the call centers. So thinking about low resource settings, I think it's very brave of IAMO. It's not something that's common. And congratulations on your presentation at the Global Digital Health Forum. I think everyone was very excited about that. I'll come down now to challenges. It's not all right, and they are challenges. So throughout the insightful contributions shared by our panelists, we've gained, a deep understanding of the transformative power of AI in reshaping public health. From personalized medicine to drug discovery to AI working in supply chain, and AI being there, as Dr. Hamid mentioned, for many, many years. However, with any powerful tool, the widespread integration of AI in public health also brings forth a set of challenges and limitations that need to be considered. Governments right now are operating, trying to put regulation in place, and they're moving with caution. While AI holds great promise, it's crucial to understand the barriers that stand in the way of effective deployment. So in your experience, and I'll ask maybe two of our panelists, what are some of the key challenges and the limitations you've encountered when it comes to implementing AI in public health, and how can we address these challenges? Maybe we can start with Elena, since you just spoke about your AI work, and then maybe we can go to Dr. Hamid.
Sure. Happy to keep speaking to this. So key challenges and limitations. I mean, there's a number of them. What I would say is, I think what sometimes we can fail to do is to ground ourselves in the realities of implementing and designing for the type of technology that people are working with, the type of needs they have. I think Gen AI can play a big role in equalizing and leveling the playing field, but it also runs the risk of furthering disparities if it's not designed for the people that it's intended for. It could exacerbate sort of existing health disparities in these spaces. I think one key place that this fits in is not only in sort of the existing data sets that these models are pulling from to generate responses from a health perspective, but also from a language perspective. I think there is a huge need to invest in specifically African language data sets, and language inclusion is really important. There's a number of languages that are supported or online, and those tend to be Western or European languages with a small smattering of others, but there's almost 6,000 plus languages that are not supported, not online. And that's a huge bottleneck to making generative AI in anything that we do inclusive and ensuring sort of equity and representation of this technology in not just the health space, but in the agricultural space and the financial inclusion space. I mean, there's so many use cases, but without the language component, we're going to fall short.
I like the idea that you brought out on exacerbating disparities. I think we've seen examples of that they didn't call it like garbage in, garbage out. When you put in, it's the data that we put in. And you brought up something about African language data sets. I think that's an area definitely that if we are to leapfrog as Africans and to join the AI game, is that we need to address how our data, first of all, is how clean our data is, how it's formatted, and looking at the languages that we have. I'll move on to Dr. Hamid. What do you think in your experience of the challenges of AI implementation in public health?
Well, I couldn't agree more with what Elena had to say about a number of things. I didn't want to talk about this, but since this came up, I want to highlight the this point about the asymmetries of access in all of the senses that you described, language and data and whatnot. But to put that in historical perspective, this is actually the topic of this last book that I co-authored with my colleague. But there's a history of asymmetry in universal access across the board, in the sense that, oftentimes, governments and people with resources think that universal access is a only benefit to the marginalized groups and a cost to the system or to the government. And I think there's a misperception there, and this is what we have tried to clarify in the book, that actually there's also a flip side, namely that there's a huge benefit for the society and to the government when they invest in things like this, right? So let's not just forget that this is a mutual kind of game where not only the marginalized benefit, but also the society, and for that matter, the government. And it's important to keep this in mind, when it comes to AI as well. So I wanted to just highlight that in a kind of historical sense. Rather than dwelling too much into predictive analytics and so on, which is what I intended to do, I am sure you all are aware of the difference between this and statistics. Some people describe these predictive techniques as statistics on steroids. There's some accuracy to that, but it's more than that. And one aspect when this is different is, this topic or the issue of personalization. That is, if you go to the next slide, actually. No, let's stay with this. Sorry, if you don't mind going back. Yeah. So that example on my third bullet point, whereas forecasting estimates the total number of ice cream cones to be purchased next month in Nebraska, let's say, predictive technology tells you which individual Nebraskans are most likely to be seen with cone in hand. That's a simple example of how different current techniques are from old, statistical or forecasting techniques, in the sense that, yes, you could in the past with forecasting, techniques could predict how many people are going to be consumers of, let's say, ice cream, or, more health related, let's say, of certain types of medications and so on, right? But now we can say, more accurately, which people are more likely to use which types of medications, let's say, or engage in certain types of health-related behaviors based on their history and where they fall into different categories. So I just wanted to start on that note. And with that, if you please move to the next slide. This is exactly what we heard from Elena and from Gideon, that the current practice, especially in the US, most of what I say comes from a US perspective, but I assume that it also applies in some ways to other parts of the globe. The fragmentation of health is a big issue, meaning that people go to different providers, to different systems, and these systems do not always talk to each other. They are not interconnected. That's very vividly was displayed by the slide that Elena showed us at the beginning. Second of all, health tends to be task-oriented. That at least in the US, the compensation system focuses on what procedures are done, what types of activities or tasks providers have provided, rather than a holistic approach that would focus on human beings and human bodies as wholes, not just as a set of parts that could be dealt with by different experts. That's a huge problem, I think, in the current health system across the globe, to the best of my understanding. And lastly, current practices, especially with technology, are gadget-based. That as this phrase goes, there's an app for everything that we do. But how do these apps connect with each other? Again, Elena showed us a very beautiful slide of they do not always talk to each other, right? So this fragmentation and the splintering, if you wish, of technology and expertise and so on is a huge, huge issue that we have to be wary of. And AI might actually be helpful in some ways in integrating this. So if you go to the next slide, just to put this in perspective, I just quickly want to walk us through, this is not something that you are not aware of. I'm sure you're much more familiar with this than I am, but I think the slides are maybe, if you go to the next one, is it maybe, yeah. So this should have been before that. So in the 19th century, people in the US and many other places were visited by doctors at their homes, right? As I showed in the previous slide, in 20th century, that moved to institutions and, health settings and so on in here. So people go to clinics and hospitals and so on. If you go to the next slide, then 21st century, this is what is happening, right? That is, we have health providers at different levels, individuals, neighborhoods, communities. We have different settings, from home to facility to hospital. We have multiple contexts, rural, urban, suburban, and so on. And also, a new trend of multiple generational settings. That is, which is I find very promising, actually, especially with the aging population, putting different generations together in the same setting so that they can benefit from each other's, skills and histories and so on. So these are, in my mind, these are the big challenges of the current health practices. And if you go to the next slide, I think this is I already talked about that. The next one, perhaps. Yeah, okay. Let's leave this for the next round. I hope that I didn't confuse you with because the slides were a bit in the wrong order, but we can continue that conversation in the next stage.
I really like what you're bringing out and working in telehealth. It's really resonating with me, the history of how we've been seeking medical services. I had a conversation today with someone and I said, we're working in telehealth and we're trying to convince people to seek services from their home, and it's difficult. Why wouldn't anyone want to receive the services from where they are? I think it's a lot of mindset shift and there's a lot of fear. In my experience, what I'm seeing as major challenges, especially for the African context, and I say this to governments as we're speaking and giving advice on how they're going to move forward in the AI journey, is key considerations: infrastructure. Africa does not have the infrastructure needed to start up and maintain AI solutions. And the big thing that people don't even want to talk about is, it's hot topic. Any problem you have, let's do AI. Any problem you have, it's like when blockchain came out. Everything problem that was coming out, let's use blockchain. Let's use blockchain. We need to really focus on the problem. What are we trying to solve? How is it going to be more efficient? And I like the idea you brought about interoperability. It's the siloed behavior everywhere, not just in data, just in implementation. If you can build a large language model that someone else can use and continuously use in the way they should, why can't you make that available? So that siloedness and the lack of interoperability, the AI is only as smart as the data that it's trained on, right? So we need to have multiple data sources. So I really like the points that you brought out, Dr. Hamid. I'll move over to Gideon. You said you're working in supply chain. I imagine there's some challenges in the way you're implementing AI. Can you highlight some of those challenges, please?
Yes, these challenges are not any different from the ones mentioned. However, I will try to localize it to what we find here. I think one challenge is the lack of education, AI education in data and AI. Going for needs assessment, the response was quite shocking. A lot of people are scared when they hear AI. We don't want a scenario, an end of the world scenario, a system that would kill us all. That is what I hear. I see this apprehensiveness, people being scared, people being worried, and that is why the need for AI literacy. It's very much there. We have to educate our health workers, everybody who's involved in that flow. We have to do that. Then the issue of data quality. unfortunately, it is a challenge to get a very good data. And like you mentioned earlier, the AI is only as good as the data it's fed on or trained on. So that is another issue. And that is why there's a need for standards, data management standards across the world. The Digital Square, something Digital Square by Path, an organization, they started working on an LLM project across Nigeria, Kenya, and Rwanda. And what they were doing, they're trying to build an LLM, working with the Ministry of Health across these countries, and kind of develop a system of which they can then build AI tools for health use cases. It's a very good move. By the way, it is a very good move. But one of the challenges they also highlighted was the fact that the data they get are not really that good. So this is the same challenge we are facing here. And if you go any other country in Africa, we have that challenge. How can I get, you see, you go to the hospitals, even in the remote facilities, you see where they keep their books, they still use manual paper filing system. We don't have computers. Even if we do have computers, do we have power? So the infrastructure is another challenge. There's no power, there's no connectivity. How do we sustain this? And that is why, while we are trying to build systems in Uganda here, we're also trying to look out for these pitfalls, these challenges that might derail our progress, and try to account for them. Of course, these are not permanent solutions, but the sustainable pathway or way out of this challenge is to ensure that tech infrastructure are there. There are standards for data management, interoperability standard for linking systems together. There is a training, AI literacy amongst the workforce. And that is why when I mentioned about the apprehensiveness of health workers, when I did mention about the AI to them, it just shows the need for change management. Take it or leave it, AI is here to stay. Within a couple of years, everybody will shift. And those who don't move along will get left behind. And those who can't be left behind have to be trained, supported. And that is where the change management comes in, so that they can be transitioned into the new order. AI is here to stay. We are happy, but these challenges are also very, very not good for our work.
I really like that, Gideon. I heard someone from the other day say, health workers are scared that AI is going to take over their jobs. And he said, AI is not going to take over their jobs, but doctors who don't use AI will lose their jobs to doctors who use AI. It's a whole list of things of things that we're looking at in terms of challenges. And what we are seeing in Africa is that African governments are now coming in and trying to put in stricter regulation to ensure that they protect themselves, they protect the country. And I think we need to think about the ethics, right? So Zambia, Malawi, and Tanzania have put up really strict data protection laws, data hosting laws, but they don't have the infrastructure in country to sustain or even start up AI solutions. So they're missing out. They don't want the data to be stored in the cloud because of issues around ethical considerations. So I'm going to go into really my next question. So ethical concerns in AI applications span various issues: data privacy, informed consent, equity. How do we then ensure that AI systems are transparent and accountable? How do we safeguard individuals' privacy when AI is analyzing personal health? How do we ensure that big tech or tech companies do not take advantage of government health data to build models that they can then make profit afterwards? And how do we bridge that gap? I'll start with Elena, especially working on Gen AI in public health. I know there's a lot of caution there, because if the AI gives a wrong recommendation, that's something that the government would want, to cartel. Who takes accountability for the issues that AI produces?
Yes, this is such a good point to bring up. Thanks, Jessica. Well, your last point, what guardrails are in place to protect our users from getting the wrong information. I could speak a lot about that, specific to Viamo, but going back to your original question of how do we ensure equity and data privacy and informed consent? And to get into your point, AI is here to stay. So we need to integrate these guardrails, these safety nets to protect our users. I mean, we've seen on the news Meta, Amazon, huge fines, billions of dollars for misusing data. This is not specific to the conversation we're having. This is, across the globe. And NGOs are not immune. I see a lot of our attendees, they work for NGOs across the continent. So some just like quick things that come to mind are anonymize data as much as we can. Don't collect PII if you don't need it. In fact, just don't collect it. It's really hard to manage the risk of protecting that information with rigorous systems. So if you can, just don't collect it. Setting rigorous regulatory systems that are in line with any sort of protocols. I know there was an AI legislation that just came out related to certain countries across Africa that you mentioned that was just released like 2 days ago. I'm not sure where that was actually done, but those need to be integrated into the organizations that we work with, into the frameworks we have. I think a good standard is, especially if you work across separate countries, to have the most rigorous framework that aligns with, the different standards that are being put out, and just synonymize your systems with those protections on our side. That's our responsibility. I think another point that you brought up here was around consent, and thinking about the topic of consent. It has to be really clear and really understandable to whoever is offering consent what that consent extends to. And there needs to be a system in which they can also revoke that consent. That is, just saying, are you okay with X? You need to make sure that it's relevant, understandable, and that that's clear to whoever's offering it. To your question around, oh my gosh, I'm looking at the time, so I probably can't get into all of the safety guardrail pieces we have in place to reduce hallucinations, to ensure accuracy of responses. There's a lot of them. And I guess my point here that I'll just land on is everyone's using AI. Everyone's been using AI. We're going to continue to. And having regular evaluations of the potential harm, the potential risk that's in place is really important to amend these systems as we move forward, especially as we move into the world of health. Move slow, go low, go slow, build those systems before you launch it at scale.
Thank you, Elena. And I think from my experience, our recommendations to government is not to start now to put really strict regulation, but to consider regulatory sandboxes to create an atmosphere where people can operate and they can learn and, let AI flourish, and let's see how far it can take us, but in a controlled environment. I'll also pass this back to Dr. Hamida. I know you have a lot of experience in AI. I would like to know from your perspective what you think about ethics and big tech, or even just normal tech companies taking advantage of people's data, not compensating, just the ethical considerations in that space.
Great questions, great conversation. Yes, thank you, Anita, for bringing that last slide in. You gave us the key word here earlier on, Jessica, and to me, that is profit. I think, what is happening here is that a lot of innovations in AI are at the moment, because they are, they take place in major, big tech companies. It's not a secret that almost all of them are in the U.S., and not only in the U.S. In the place where I am at the moment in California, the sun just came out. I wish the sun could shed some light on this aspect of the conversation as well. Look, Elena already mentioned this, Gideon mentioned this, that AI is going to stay, but the real question is, in what shape? Yes, AI is going to be here, but it is that second question of what type of AI, for whose benefit, that's up for grab. And I think to just start my next few points with that point in mind, with that idea that it is really not already set in stone what type of AI we are going to get. And there's going to be a fight to be fought. I mean, I'm not going to be shy about that. There's a fight to be done across the globe against big companies who have taken control of this, right? Not only in terms of data ownership and data, use and so on and privacy, but also in terms of profit. So I think, privacy is important. Issues that Elena raised are very important. But I want to also caution us not to overemphasize privacy, because these other issues are, in my understanding, are maybe more important, in terms of health impact. So we saw this during COVID, that our best tool for fighting COVID pandemics was surveillance. So we need to make sure that we balance, our concerns with privacy with surveillance. What I'm trying to show on this little figure diagram is to exactly highlight these points, that at every level of machine learning, and as you all know, there are at least 4 stages. What I call monitoring, data collection, then mining the data, and then marking that data, putting labels and so on, and finally using those labels to manipulate things, to push things in different directions. At each of those levels, there's a spectrum of possibilities. So you can have, on the left side, if you focus on people and the benefit to the public, you can bring about awareness and discovery of new patterns, or personalize things, or get people involved and allow them to participate. But on the right side, if you look at all of these as commodities for profit, if you look at data as a source of profit, if you look at mining as a source of profit and commodification, if you look at these personalization tools as means for marketing, and so on. If you take this approach on the right side of this figure, then of course, you land with bad practices, of intrusion and distortion and discrimination and exploitation even of people's data and so on. So my way of thinking about all of this is that there's a spectrum of possibilities all the way from the left to the right at all these levels, and depending on what resources are allocated and controlled by whom, and what type of fights are going to be fought in the future between these big corporations and the rest of us, then the outcomes are going to be different. And I think I want to use this moment actually to invite all of you, who are in health, to help people in technology, such as Gideon, such as myself, to help bring awareness to the public about this. And I also want to use this opportunity to offer my hand here. We have we are a university here with some resources and so on, to suggest that we would be very happy to cooperate with any of you on the panel, but also in the audience to launch what Elena described as, and Gideon as well, as health AI literacy, essentially technology literacy, for people to understand this, to remove this mystery around that AI is wrapped into. It is not as magical as it seems. We can make it much more transparent.
I like that last bit. It's not as magical, like it's going to solve all our problems. It's a lot of work. It's a lot of collaboration and working with different people and really understanding. We're almost at time, so I want to go and maybe go to our audience and check if they will have any questions. Anita, do you want to manage the Q&A for us, please?
Yes. So we have 2 questions that have come in. The first one, the question asks, how can AI support diagnostics of mental health conditions, especially in rural communities, primary healthcare, PHC settings? How can AI support mental health services referrals, especially in primary healthcare settings?
That's a very specific one. I'm not sure any of our panelists who wants to take it.
I'd like to go on that. Of course, I like to look at it from the lens of mental health is the same as any other disease we're trying to use AI to solve. Essentially, we've seen tools, AI tools for nutrition disorders. We've seen. So I want to take that approach to answer that question. Yes, mental health can be used. Sorry, AI can be used for mental health. For me, I do play a lot with these tools. I developed a cognitive behavioral therapy app that tries to diagnose, have this conversation, and then pick out what exactly is wrong with this person, and then try to kind of provide a therapy, as a way of salvaging the problem. But something very important I'd like to mention is that because mental health is a very delicate thing, we always like to bring about the human in the loop, whereby you explicitly have to refer to a professional who is trained in that regard. So whatever mental health AI app or tool you see there is just the front line. It's just the first aid. It's not the main treatment. It should serve as a tool. And that is why a system that is robust should connect to medical services, provide emergency lines for people who want to, self-harm, who want to cause problems to themselves or to others. So we do have that tool. And like I said, like every other AI tool we use in the healthcare, we try to make sure that it is close to the nearest person. It is accessible on any device, be it the USSD, the mobile phones. It is in different languages. We try to even provide the option of a text-to-speech, whereby you can talk, it responds, and just like ChatGPT does, you give it that functionality so that somebody who can't type, who's not a proficient to type, can speak and get responses. But then the human oversight, because AI is as good as the data it is used to train upon, it can mislead. We've had a case not recently of a child or a teen who committed suicide. We also had another issue of the Gemini from Google telling somebody to go and unalive himself. So it tells you that they are not 100%. That is why personally, for mental health, I'm a little bit careful about that, because anything goes wrong, things could go really bad.
Elena, you want to add to that?
Yes, definitely. Gideon, thanks for that. So one thing, this sort of responds to both of the questions asked here. On the subject of mental health, or specifically health, I think human in the loop was a great phrasing that came in here. And something that we're doing to manage the risk and manage and put those guardrails in place to protect our users is, I mean, I sort of alluded to having two products. One, Ava, that connects you to the World Wide Web. The responses you're getting are generated directly from a large language model like ChatGPT. Then that's personalized or contextualized with prompt engineering. It's localized to the context. It has guardrails in place, but you're still getting your responses from a ChatGPT, a Gemini. Then we have another product that we use to manage the risk of hallucinations and to ensure that the responses are really highly monitored and highly specialized. And that's when we actually create like a specific universe of knowledge. We have content stores and content domains that the voice companion is trained on. So in that case, we use something called retrieval augmented generation, which stands for RAG. And what it means is we're pulling from a very specific universe of knowledge from very specific content that's approved. And that's what that voice companion is trained on. Then it's filtered through an LLM, a large language model, that conversationalizes the response. So in that way, we have more control over what the voice companion can respond to and make sure that there's less chance of hallucinations. We have full control over the content. And in spaces of health, it is quite important to put those guardrails in place to protect. I think it also relates to the question that Dennis asks about increasing trust from the beneficiaries of the system so that we can both benefit from this. One thing is that it works for them. It's one thing to create a system that is not relevant, is not engaging, they don't trust. So the more types of personalization that you can add into the system, and that it's a dynamic conversation. So if someone calls in and they say, "Hi, this is Joy. Can I get pregnant from a toilet seat?" And the response goes, "Hi, Joy, let me respond to your question." Responds, and then asks maybe, "Do you want to know more about pregnancy and sex?" And it's a really an empathetic level, a personalized level. The responses are catered to the profile of the user. Those are all ways in which I think can inspire trust that the responses are relevant. Of course, we also can't apply, we have to contextualize. There has to be this level of prompt engineering so that the responses make sense for the people asking them in the context that they live in.
I like that. And I think we need to really understand that there's certain cases where the human element will be very important, either to check that the fact is there or to bring context that, AI is not yet developed to give out. I can imagine in mental health, if someone wants to, commit suicide, how the AI would trigger to get that person support, that you need those emergency services and the guardrails as well to understand what the person needs. I don't know, Anita, if we have any other questions, because I know we're almost at time and I wanted to wrap up.
Let's see. Oh,
Yeah. Go ahead. Sorry.
Elena touched on the second question. So I don't know if Dr. Hamid wanted to add to that, but then we can move on.
I just wanted to highlight one fact. There was a report in The Economist a couple of weeks ago about the mental health situation in the UK, and how, there's, in some cases, first of all, the number of ADHD diagnosis is rising in all age groups, in the UK, but also across the globe. About 2 million people in England, 4% of the population are thought to have ADHD. And what The Economist did, and I want to invite everybody to take a look. This is a brief report. What it did is to highlight the fact that this approach to mental health is very, very damaging, in the sense that, we take these labels very seriously and we treat them as binaries, in the sense that either people have something or they don't have something. And it was making a case that that is not the right way of thinking about mental health. And the way this connects to AI is that AIs has the possibility of amplifying this approach by just, putting things, people in these different categories in a binary manner. And the human loop in the idea is one way of going around this. But, our health experts, also mental health experts, have to be trained themselves to not fall into this trap of labeling people. Labels are just labels. They are not meant to do more than that. I just wanted to highlight this and invite everybody to maybe to take a look at this report.
Thank you so much, Dr. Hamid. I think there's some resources being shared in the chat, and thank you for everyone who shared those resources. But we're almost at time, and I wanted to give one last lightning question to all teams. What do you foresee the future of AI in public health? How do you see AI changing the game in public health in the next 5 to 10 years? It's 1 minute each. We're almost at time, so maybe Gideon, you start first, Elena, Dr. Hamid, and then I'll close off.
You're on mute.
Mute.
Sorry. Yes, I see countries owning their systems, despite the challenges when it comes to resources in compute resources, when it comes to data mining. There's also the democratization of artificial intelligence, and current progress made by organizations, countries, shows that why Africa or lower and middle income countries are a bit slow, they are still moving. So I think in the nearest future, we will own the process. Africans, lower middle income countries, those who are disadvantaged comparatively, are going to have their system that works for them, because like we said, AI is here to stay. So we might as well start moving in that direction. Thank you.
Okay, I agree with Gideon. I feel optimistic about the future of generative AI. I think there's this concept of intended use, like instructions on the tin. And with Gen AI, it's unwritten. I mean, it's sort of endless. There are so many use cases, and actually being at this Global Digital Health Forum conference has been really exciting to see the types of work people are doing, the gaps this can fill, thinking about like, who is this intended for? What could the potential benefit be? What's the environment that it can work within? And it's just it's wide open in a lot of ways. I mean, the potential for this to fill the gaps and to bridge the challenge of equity in low and middle income countries is tremendous, and there are a lot of players in this field working towards that. And it's really exciting in the context of healthcare, how this can actually fill a gap with a high level of accuracy and change the lives of a lot of people.
Dr. Hamid?
I really don't have much to add to this. I'm very glad to hear what Elena just said, that there are people on the ground using these. Maybe this is a moment for us to avoid the historical pattern of asymmetries that, the developing countries and communities were used as guinea pigs for testing, different types of, things. But maybe this is a moment for the possibility of democratization, but with the caveat that we really have to be, ahead of the game and, fight, for people's rights, and this country's rights to their data and everything else. Thank you for that opportunity.
Thank you so much to our panelists. I think for myself, when I think of the future of AI in the next 10 years, is really having the ability for real-time, maybe patient or predictive analytics. Putting people at the center of it. I can imagine AI in the next 10 years being able to predict pandemics before they actually escalate, and we are able to contain that. To wrap us off, we're actually at time. Thank you so much to all the panelists for sharing your incredible insights, and to everyone and the audience for joining us. The questions, the conversation has been inspiring, and I hope it sparks, something further dialogue and collaboration in the field of AI and public health. So I'll hand over back to Anita, but thank you so much.
That's all the time that we have today, but thank you so much to our panelists. This has been a wonderful and informative session. I want to say a huge thank you from GHC to our moderator, Jessica, to our panelists, Dr. Hamid, Elena, and Gideon. I appreciate your time and insights you have shared with our attendees today. Thank you so much. As a reminder for all our Global Health Corps community members on the call, please share your insights, research, learnings, questions, or the support you or your teams need on GHC Connect to keep this conversation going and share the wealth of information we have in our community. Thank you again to our panelists, and we wish you all a wonderful and healthy day. Thank you.
Thank you. Bye.
Bye.